Welcome back, listeners, to Diversion Insights. My guest today is Dr. Jenny Dolan. Dr. Dolan is the Division Chief of Pediatric Anesthesia and Director of Trauma Anesthesia at Johns Hopkins All Children's Hospital. How many of you listeners out there wish they had better partnership with the anesthesia department? I've been there, frustrated by what anesthesia providers may call documentation errors, but what I call unaccounted for controlled substances and possibly a sign of diversion. Today, we're going to hear from someone who took that seriously, which resulted in change. Welcome, Dr. Dolan.
Thank you. Thank you so much for having us.
Absolutely.
We are very excited presenting our quality improvement project.
Yeah, I'm sure the listeners are going to be very jealous that many of them are going to wish that they worked in a location that took it as seriously as you did. So tell us about your quality improvement initiative and what prompted it.
It was prompted by our director of pharmacy. He identified our total number of monthly discrepancies as a problem. And he came out to us with that situation. It was both important from the safety perspective and also from the regulatory point of view. And the safety both for patients and clinicians, and then the regulatory aspect. He thought it was bothersome that our total number of discrepancies a month. And you know that the Controlled Substance Act is very specific about delineating how important documentation is for them from the regulatory point.
Sure. Yeah.
So we were presented with that problem, and we decided to proceed with a quality improvement project to aim to decrease the number of discrepancies. Our initial goal was to decrease our number of discrepancy by 20% of what we had. But through our quality initiative project, we were able to come up with a 71% reduction.
Wow. Fantastic. And, we talked at length about kind of the relationship between pharmacy and anesthesia department, and often the standard response from anesthesia is, we're busy and this is just documentation. And you shared something with me that kind of hit you, that I think it was the security director that said something to you. Do you remember what that was?
Correct. Our security director, while we were having these conversations, I mentioned we are a very busy practice. We take care of difficult patients. This is going to keep on happening. And he said something in how can you say that the care of the patients is excellent when you are not able to have adequate documentation. Something like that, he said, and that resonated with me. It is true. How can you confirm that you're providing excellent care when you don't aim to also excellent documentation? It is like when you have a surgeon, the part that the family sees is the wound, the closure of the wound. So to me, the documentation was that what the family will see also if they were to look into the case.
Right. Yeah, I like that. Yeah, it is. It's understandable that the workload it's busy and there are things that happen, especially I'm assuming at the beginning and the end, but it's the detail, right? And I've always left when I say, well, if that detail can't be taken care of, then what other detail is maybe not being addressed properly? So I think that's fantastic that you recognized that and you guys made some changes. So let's start the discrepancies that the pharmacy was seeing and the department was making. What kinds of discrepancies were those?
The discrepancies were in documentation. One of the most common error was the retrieval of medication without documentation of the medication being given. Let me give you a baseline of the data. In average, we did, those years, we did around between 14,000 cases to 15,000 cases a year. And every month we had around 41 discrepancies. And the main reason was that one. Then also we had undocumented waste. Let's say that we retrieved 100 mics of fentanyl. We gave 80, we documented 80, but there was no documentation of the waste of the medication.
Mm-hmm.
Those are just examples of the type of discrepancies we had.
Right. Okay. And, you know, when we talk about diversion versus just truly simple documentation errors, what are your thoughts on that? You know, obviously the pharmacy was having trouble with, you know, is this diversion or is this just missing documentation, which is still a regulatory issue, but it kind of blends together. What are your thoughts on the difference there?
When the problem first came, I didn't have a sense of that anyone from my team was having diversion problems. But definitely I saw it as a clinical problem after the conversation that we just mentioned. But then throughout the development of the initiative and throughout the project, I could see that perhaps there could have been diversion. So on those instances, when we saw outliers, then we dived deep into their cases. We went ahead and took care of the amounts. We look into patient's outcome. We look into pain scores in PACU. We look about volumes, all that kind of things. And at the end, we could not prove, or we have no reason to believe that there was discrepancy. Can I say 100%? Are you sure of that? No, but we couldn't find any evidence of that other than very sloppy documentation.
Okay. All right. Yeah, that makes sense. It sounds like you were pretty thorough in looking into things. So you ruled it out as much as possible, and that's great. So you chose the theory of change over other QI methodologies. Was there a particular reason you went for that?
I choose the theory change as the framework for the quality improvement project because first I was familiar with that framework, and second, to me it was a framework that allowed for flexibility, and it is designed to tackle this type of chronic issues, and this was a chronic issue that we have. And this theory of change, the backbone is that it makes the assumption that every time you put an intervention, there's going to be a change in behavior. And it allows you to map the problem, you identify the problem, you define what is your goal, and then you map how are you going to achieve that goal. So I thought it was the ideal framework for our problem at task.
Okay, it makes sense. Yeah. How did you engage the stakeholders? So you obviously needed your anesthesia staff on board and pharmacy, I would assume, and informatics potentially. How did you engage them in the planning process?
Obviously, pharmacy was on board. They were the ones presenting the problem, and through conversations with the team, consistent, regular conversations with having meetings, presenting the information and the data of why we have this problem and what could be the repercussions at the institutional level and also at the personal level in terms of licenses. So presenting that information and making people aware and allowing them to ask questions and understand why this is important, then I got buyout by the vast majority of the people. I can't say that everybody bought into it, but that's what we did. And I think based on the results, at least the majority of people took this seriously.
Okay. All right. So let's talk about what you did. I believe this was over 2+ years and maybe 7, I think, different
almost 3 years, 7 interventions.
Okay.
I use the logic model as, let's say the logic model is like the blueprint or the roadmap, and then the theory of change is like the vision of what is it that you want to achieve. So with the logic model, I use it as the map. You have the input or resources. Then you have the different activities. Those activities are the interventions that we apply through the time of the project. Then you have the outputs or the results, and finally you have the impact and the sustained change that you were aiming through the theory of change. So we start by first the meetings with the team, explaining everything that I just mentioned. Then we start by presenting the data. Initially, we just had an Excel spreadsheet where we will document the discrepancies. We identify the providers. We identify what was the error, and then we started by presenting it. I think then the next intervention was placing a sign on the anesthesia machine so that before you will close the chart, it says, please verify that all the medications are documented correctly. During the implementation of the quality improvement project, we realized that the vast majority of errors were made by transferring drugs from one patient to another. We used to have the capability of, let's say I pulled the drug for a case that just got canceled. I didn't draw the medication, it's brand new. Instead of returning the medication, you could have the option of transferring that drug to another patient. And that was the reason for many mistakes. People will either not transfer the drug, or if they will transfer the drug to a different patient, when the time came to waste the medication, they will waste it on the wrong person. So we came with a difficult position of saying, we are going to do this. We are going to disable the ability in the dispensing machine of doing that. That was obviously not popular. I think I had a big target in my head. People were very upset because it was convenient, Then with each intervention, we saw some type of change. We identified that the Excel spreadsheet wasn't ideal. It was only few people had the the advantage of being able to review that data. So that's when we got in contact with data analysts, and we decided to develop the board with the visual analytics. And we came out with ideas of how to present the data and what type of data needed to be presented. So we saw that, the other intervention we implemented was tying the compensation of the physicians to the narcotic discrepancies. And we saw that from all the interventions, the one with a big impact was disabling the capability of transferring medication. I would say that was the most significant one in terms of numbers. Then tying the compensation with the physician, because, okay, the CRNAs in most of the time will be the people retrieving the medication, and but if you don't have a partner in the operating room that double checks what you are doing, that helps you with the wasting and everything, it becomes a very difficult task. So we thought that having the physicians having a skin in the game, can I say that?
Mm-hmm.
It was important for them to then make sure that they will help making sure that the documentation will be correct, and helping with the wasting, helping with everything related with patient care and documentation. So the disability of the transfer, the physician compensation, and then the third big intervention was the visual analytic, having the data being presented clear, on time, and having the transparency of having your own data and being able to compare yourself with your peers. I think that had a big impact also on how people behave, and how people change the way they conducted their documentation.
Right. You made it a visual that everyone could see, right, and compare themselves.
Correct.
Yeah, which I think, nobody wants to be the worst on the list. So they competed against each other. And I believe you said you put something else in that space that people wanted to look at. So they were.
Yes, we made it kind of fun. We will have jokes, medical jokes, rated R or PG-13, obviously. We will have pictures of the team. We will request pictures of the families of all the clinicians. So in between those pictures, then you will have the data. So people will look at the world, and people will look at the data.
Right. That's clever. That's clever. So has the change been sustained? What kind of
Yes.
change did you see?
Actually, the change has been sustained. So we went from having 40 plus discrepancies, and now when we review the data, we are every month perhaps 3, at the most 4. So the change has been sustained, has been consistent. And I will say we are not just at that 71%, we are at, if the numbers are not wrong, around 92% improvement.
That's
We went
fantastic.
from having 40 discrepancy to only 3. And I think,
Right.
just not the quality improvement program, but also regularly meeting with the staff, and making sure that they understand how important it is, keeping that communication with the staff has been important in sustaining that change and keeping it that way.
Yeah. Have you noticed any other changes or improvements that came out of this that maybe isn't necessarily measured in data, but just the outlook that the staff has now on controlled substances or accountability or anything, any
Definitely,
byproduct? Okay.
definitely, and you can see the difference. Like when we have new people arriving to our institution, you can see the cultural shock of how we see controlled substance, the management of controlled substance versus how they used to work and how they used to see that. Um, that's something that definitely is palpable. And so we try, perhaps we can do even better. We try to make sure that new staff, new learners, that they are aware of how is it that we work here, so that they are able to get on board fast.
Right.
Uh,
Yeah.
we have this program, the AI program Protenus, I believe is the name,
Mm-hmm.
where we are able to identify outliers or people that don't perform the same way than others, and we can identify them, and they are usually new people. I'll give you an example. We had with one of the learners, we had concerns because of eh, how Protenus identify them, and we did our research. We look into the cases. We look up into the amounts of drugs. We look into the mistakes that this person were doing, and at the end, we ended up calling the program director from the previous institution, and what we were told by this physician is that they had a cultural problem with a controlled substance, that they had a very they didn't they didn't have control of how the staff was
Loose.
handling the medication, and his words were that this person just took bad examples and practiced in a very sloppy way. That particular person said, I don't think this person has a diversion problem. I just think she pick up bad bad behaviors
Yeah.
from our hospital. And he also mentioned that just recently they have started working on improving how they handle medications and how they document medication.
Right. Yeah. Well, with all of the cleanup that you did and the sustained improvement, you now have eliminated a lot of the noise, right? So you can look at those outliers and then drill down into why they're an outlier and then focus on either that improvement from a practice standpoint or, take it in the other direction if you think there is a substance use disorder at play.
Yeah,
So,
and I wanted to mention also the presentation of the visual analytics. It wasn't well received by everybody. It was a hard. I will say it was a hard implementation. The outliers, a couple of them were very resistant to it. They got upset. They claim oftentimes they claim discrimination, harassment. So it
wow.
was important for me to have to be supported by my institution as a whole, to be supported by HR, to be supported by the pharmacist, to be supported by my whole group, and in general by the directives of the institution.
Sure.
Because obviously, if you are not performing well and you don't see the problem, you are going to claim any type of you're going to claim that you are being attacked, you know.
Right. Right.
Um,
Which is such a shame. You kind of have to wonder why. I mean, just improve. Don't, yeah. So, but the support, that's really important. What would you, if another hospital wanted to replicate this, what would you say are the three most important things? It sounds like the support, you are all
institutional
speaking
support,
the same message.
institutional support, a strong partnership with pharmacies, very important. And then you have to apply the fundamentals of data presentation. Also, they also call it the 3C: clarity, accuracy, and context. Um, the data has to be simple, that the people can understand. That's clarity. Then accuracy, the data has to be real. It has to have integrity and transparency. Um, Nobody can claim that putting the names is harassment because it applies to that fundament. And then the context, the data needs to be able to tell a story, you know, to tell you why, tell a story, and show the results in real time.
Mm-hmm.
As long as you have those things, I think you will be successful on your implementation. And obviously, the buy-in. You gotta make sure that your team feels involved in the development of the project. They need to have a say on how you present the data. They need to have a say of at least they need to feel that they are part of the developing of the project. Obviously, again, you're not going to have a 100% buy-in into the project, but you need to have that
Right.
so that people it helps you and you have sustained outcomes.
Sure. That makes perfect sense. Yeah. Let's transition a little bit. I want to ask you about in the OR, the diversion specialist or whoever is leading the hospital's program often doesn't have a really good lens into the OR. So from your experience, let's talk about diversion mitigation and monitoring in the OR. What do you think are the important things for diversion specialists to understand and to watch for in the OR, and for every team member and those in anesthesia leadership to keep an eye on and to be aware of?
Um, I will say that um, something that needs to be taken into account is that you can know the pendulum cannot go to the extremes. You cannot go to the extreme where you will hinder clinical care, for
Sure.
instance. So I think even though I am in a real partnership with my pharmacists and everything, it is important for them to understand our workflow, and they do. I think that's very important that people understand what is your patient population, how is the flow of the OR, and having a clear understanding that pendulum doesn't go to the extremes where you are impairing also, because you can also impair safety when you hinder the work of the clinician. In our particular patient population, preparation is key. Because you have an unwilling participant of the anesthesia. You have a patient that doesn't want to be there, that is gonna jump out of the bed at any point. So not being prepared for that patient it's a problem. When working in the implementation of any type of intervention, everybody needs to be aware of the clinical work. and also not to impair the clinical work and safety, because controlled substance diversion is a safety problem, but not allowing the clinician to work well, it also can become a safety problem.
Yeah,
So that will be my recommendation for everybody to understand, and be able to understand how the system work and how the clinicians work.
yeah. Do you have any thoughts for if at an institution where maybe the pharmacist in charge or diversion specialist, whoever it is that has that role, maybe is not confident that the chief or whoever their point person is in the OR is maybe giving them completely accurate information? They're just, oh, we're busy, we can't do that. How would you advise them to kind of cut through that?
I think in my personal situation, I am motivated by data and information. So I think if you come with solid data, if you present the problem with numbers, sustaining your claim, I think people will pay attention to you. But I will say that that's very important. And then benchmark your data. Identify why it is a problem. Okay, we saw that it was we had 40 cases, 40 discrepancies a month. Okay, it was I think the literature talks, the benchmark is around 15%. We had a 3% problem, but that 40 number, it was too much in my head, and I saw as an opportunity for improvement, that 40 number, even though it was just 3%. So having accurate data, having numbers, and presenting the problem, I think that will, I think that people should jump into it. I think you will have a better collaboration and an open communication, just conversation, not just write the email. Make an appointment, sit down with the clinician and present the data. Have those conversations, And if that doesn't work, perhaps you gotta escalate the problem.
Yeah, building the relationship, presenting the data, and then escalate if you need to. Yeah, I like that. That makes sense. Perfect sense. Okay. Anything else that you want to share with the listeners about the OR in general or your project that you did?
That there's always opportunity for improvement, remaining stagnant should not be an option in medical care. So seeking those opportunities and tackling them, it should make a meaningful change in the patient safety and overall the patient satisfaction and patient care.
Love it. Thank you. Thank you very much. I appreciate your time, Dr. Dolan.
Thank you. Thank you so much.